So let's move on, and now let's talk about trauma, methods of decontaminating patients when transporting in cases of CBRN threat. So our speaker is the manager of program manager of Lviv Territorial University, adjunct lecturer of Griffith University, Haley Uren, and Med Global board member, orthopedic oncologist, um, Hudson Berry, orthopedic surgeon, Med Global volunteer.
We can have the, okay. Good morning, and as you can see, I'm not Haley. Haley is much better looking, and so this is my 13th trip to Ukraine in the past 2 years or so. And one of the things that I have noticed, so as a way of background, I'm an orthopedic surgeon, okay? Orthopedic surgeons are used to dealing with we love our tools, we love our operations, we love that our patients get better. But as an orthopedic cancer surgeon, I deal with very difficult problems. So a third of my practice has been in cancer surgery, a third has been in amputation surgery, and a third has been dealing with infections. And as I have realized over the years that treating bone infections really can be much harder than dealing with bone cancer. Because I never know that with cancer you have one of two outcomes. But sometimes you never know whether you have successfully treated the bone infection, unless the patient goes all the rest of their days and it doesn't come back. And even then, I'm not sure. I'll have to check on them when I get to heaven. Hopefully that won't be for a while. Excuse me. There we are. Okay. So, next slide, please. I've got the clicker here. So this project is the result of Haley and I and many others working together to try to find a way to disrupt the development of these very difficult antibiotic-resistant polymicrobial infections. So we have many people working around the world to try to come up with a solution. And these are some of the people. Ms. Uren is from Australia, so that's why you have the kangaroo up there with her. We have Colonel Humanuk, who's a vital player in this story, myself, and a host of others. So what happened? How do we get to this situation? Well, as you know, Ukraine obtained its independence and has fought for it. It has worked very hard to update its medical systems. And part of this has been with the help of the United Nations and the World Health Organization, and having to then improve upon and develop far beyond what was happening in the Soviet era. And this was difficult, and this goes back to 2015. So in 2019, the Cabinet of Ministers met, and documents were prepared to institute changes and reforms within the Ukrainian healthcare system. All looks very good. But then what happened? Well, for the most part, everything stopped except the war during the period of the COVID pandemic and the world's response to that. So then we further looked at implementing modern infection prevention and control guidelines to deal with the infections, because this is not an issue that is unique to Ukraine. All of our developing world has issues with antibiotic resistance and polymicrobial infections. And it is now, I think that dealing with infections in today's world is much like we were dealing with cancer 40 years ago. It's that mind change, because dealing with infections can be much more challenging and may have a greater impact on patients' lives. So we're going to get new structures, new policies, new implementations of directives to work in the healthcare space. So then what's happened is so now we find ourselves in a situation where a lot of funding that came through USAID has been limited. The World Health Organization pledged support to train enough infection prevention, infection control specialists, but that has dramatically fallen short. One of the issues that we have with our patients in our hospital settings is that we have a insufficient number of nurses to be able to care for our patients in what we would consider our Western standards, with infection control nurses, a low 4-to-1 or 6-to-1 ratio of nurses to patients, or patients to nurses. And this was supposed to be, and all of this was supposed to be developed over a period of about 20 years. But then what happened is we had the war, the full-scale invasion in 2022, and everything was off, and the patient load dramatically increased. And then we had casualties on the front lines in very difficult places, and we have problems with evacuations. This is one case of a single British soldier who was fighting in the Foreign Legion, who I've gotten to know. And so he was wounded, and it took him 8 hours to get to a casualty collection point. And then it took another period of time for him to get to a point to get motorized transportation. That first 8 hours was on a litter. Second 8 hours was on a converted vehicle. And then the next half hour in getting to the initial point to get care, where they took off his clothes and cleaned him up a little bit, but he didn't spend very much time there. And then he finally got to a hospital where he could finally get some care, and he spent there less than a day. So these are the evacuation routes that patients have coming from the far eastern, north and eastern portion of Ukraine, and coming back through all these road networks, the rail networks, and a process that takes time with this. And if the wounds are dirty when by their very nature, okay. Issues that we have are initial debridement, and then there's a cross-contamination. And this is the issue that I think that we are looking at right now, is the development of infections because of the cross-contamination with other patients, with their environment, from themselves. One of the impetuses that was fundamental in developing what we're going to present was our U.S. experience in evacuating patients from Iraq and Afghanistan to our Army hospital in Germany. Everybody knows that the dirtiest place in the hospital, the place where the worst bugs live, is in the intensive care unit. So intensive care units have protocols for daily cleaning of the patients with chlorhexidine wipes and cleaning of the rooms. So we had a large problem with infections with with patients going from Iraq and Afghanistan to Germany. And so what they did is they implemented a process by which, before a patient left the theater in Iraq or Afghanistan, before they got on the airplane, they were completely wiped down, and there's a protocol of 6 chlorhexidine sponges with this to get them clean. And before they entered the hospital in Germany, they also went through another decontamination process, and that reduced the risk of the incidence of infection by over 25%. So we have bad bugs. There's a group of bugs called the escape drugs. These are E. coli, Enterococcus, Klebsiella, Pseudomonas, and Acinetobacter. And you can see that these are very, very difficult bugs to eradicate, and they are multi-drug resistant, and sometimes we don't have any drugs that can help us with this. So we can combine antibiotics, but in the best case scenario, the treatment for our infections are very, very costly. So we have 3 options. The first option is we keep doing what we do, okay? And what we're doing is we're building capacity. We're training people. We're making incremental improvements as time goes on. But it's going to take a long, long time to get to where we need to be. And it's not going to be cheap, okay? We look at what our nursing ratios are, maybe 1 to 25, and what it should be is 1 to 6, what the cost of that is for our salaries, and then what the other costs are when we start to talk about all of the cost of personal protection equipment, the PPE, the gowns, the gloves, the masks, the booties, the hand sanitizing, everything else. So that'll be a very expensive proposition. Second option is that we can mobilize our nursing workforce and try to get more nurses available for us to work. Somewhat on the same strategy as option 1, but a little bit more aggressive. And you can see that this all is very, very expensive to implement. So we think that this would cost $500 million US for Ukraine per year for us to implement this. So that's probably not a viable option. So we have a third option, okay, door number 3, all right? So we know that we have chemical warfare that is going on the front lines, okay? Mostly with the use of riot control agents, chlorpicrin and CS, and these have been used as much as the Russians used them in Syria. Russia's involvement in Syria was a training ground for what they were planning on doing in Ukraine, as well as Russia's wars on Chechen and Georgia. Okay. So what do these chemical agents do? Well, they make you feel bad. Has anybody ever been gassed? Has anybody ever had riot control gas, CS, any of that? I have, and I will tell you it's not a lot of fun. Your eyes burn, your throat burns, you cough, and you can't get out of it quickly enough. So, and these are so you look at the symptoms on this. I won't belabor this and go through each one of them. Everybody can read that. But they actually can cause death. So we know that Russia has a stockpile of dirty bombs and has these orphan radioactive sources, and they could be used to make weapons. And so what do? Well, if you look at the physical effects of these radiologic agents, they have a great overlap with what the CS, what our nerve agents have, or the riot control agents, the CS and the chlorpicrin. And they can cause death, in case you didn't know. So, you know, we've had the experience with Chernobyl, and we have the concerns about the nuclear plant of Zaporizhzhia. And so, again, it's related to the prior group, the nuclear rather than the radiologic. And as you start looking through this, there are commonalities so that if you have a patient that presents acutely with runny eyes, cough, feeling bad, low white count, or other things, then you really, where are you going to, what is your diagnostic paradigm that you're going to follow to try to figure out what the cause of this injury is? And biologic agents have many of the same type of presenting symptoms. So this was a sputum sample that Haley collected when she was at the first TMO hospital, or the Lviv Military Hospital in 2025. And you can see that there's the microbiology, you have Proteus, Klebsiella, Pseudomonas providencia, and something else. But you can see that they're all resistant, okay? And the resistance has developed because we have treated the bugs. We have not been using proper antibiotic stewardship, which is the proper drug in the proper place for the proper time for the proper patient. Okay. And so as you look at these, this is kind of a wrap-up of the last few slides, that you can see the green check marks on each one of these so that there's a broad overlap of these presenting symptoms for each of these patients, each of the types of injury. So the plan is to change our approach, adapting and modifying and magnifying the experience that the U.S. military had in evacuating patients out of Iraq and Afghanistan to Germany. We look and advocate for a similar approach in Ukraine. And what this will do is will interrupt the development of these antibiotic-resistant infections. So we know that sources of the infections are in for the patient, they're in the environment. As I said, the dirtiest place in a hospital is an ICU. We carry these bugs on us in the groin and armpits and in our skin, and our fellow soldiers have these as well. So first we want to do some basic bench research, and then do some feasibility research and working on this plan, and then putting it into having a demonstration project. So first of all, we have to look at what is the best antiseptic to use? What's going to give us the cleanest, have the most reduction in the skin flora, and can we have something that is going to have some stay-behind power? Now, there's many companies that are eagerly investing in this because this is a huge problem worldwide. And if you find somebody who has the best antiseptic for this, they're going to make a lot of money. And money is driving a lot of this. And we've talked with many companies about their products, and we have some really interesting prospects for the future use for this. So this is what we look at doing, so that when a patient leaves the initial stabilization point, they have had their damage control surgery. All right, they've been stabilized, they've been resuscitated, and at that part, before they leave the operating room at the stabilization point, they get decontaminated. So they're completely washed down, completely wiped down, so that then they are as clean as we can get them before they are evacuated to level 3. Everybody's familiar with the different levels, roles, role 1, role 2, role 3, role 4. Yes? No? Anybody paying attention? Yes? Okay. So level 1 is self-care, okay, or buddy care, okay. Level 2 is your initial stabilization point. Level 3 is your first hospital form. And level 4 then is your reconstruction, your main military or your main hospital away from this. So what we're looking at doing is taking what we have for the decontamination of chemical, biological, radiologic, and nuclear patients that we have in our NATO doctrine, and being able to take those principles, those techniques in order to bring clean patients off before they ever get into the hospital. All right? So we are not bringing germs from the front lines or from the initial stabilization points or anywhere from the journey that they have to there into the new hospital. The reason for decontamination to begin with is if you have a chemical casualty, you don't want that patient coming into your hospital. You want them decontaminated beforehand, otherwise they will be contaminating all of the rest of the hospital, and the effect of that chemical munition is magnified many times over. So this is Haley's slide as well. We want to get this quickly and thoroughly and with precision. And Haley's idea of this, which I think is good, is it's like training a pit crew for Formula One, okay? You look at how quickly a pit crew, a well-trained pit crew, can get a car off the track, get their tires changed, get the gas in, and get them back out on the track, okay? So her portion here on the left-hand side of your slide was a 1.8 second pit stop. You have to have a great crew that's worked together well to make that happen. And that's what we would like to see with this project. So the other reason this is important is because bacteria do not respect borders. You think of the patients that have been taken from Ukraine and have gone to get care farther west, in Europe, in Germany, or Denmark, or France, or Poland, or whatnot. Are they taking these bugs with them? All right. We know now Acinetobacter, also called Iraqibacter, originated in the Iraq and Afghanistan, and we took those infected patients and we sent them to Germany, and then those infected patients were sent back to the United States. And so now we have a problem with Acinetobacter in the United States. So, okay, anyway. I had a couple more slides on here, but it's fine. I think I've run out of time. This is what we are looking at doing for our future. Hopefully we'll be able to work on this demonstration. Ms. Urin finished her work at the Santa Panteleimon Hospital in Lviv, had a very good job in Australia that she was going to go back to, but she decided to stay in Ukraine really without a job because she believes in this project, she believes in Ukraine, she believes that this can make a difference not only for Ukraine, but for the rest of the world, because this is not a problem which is isolated to Ukraine. Any place you have a war, a conflict, which is happening it will happen anywhere. This will be, if Russia starts fighting NATO, it'll be throughout Europe. In sub-Saharan Africa, in Gaza, in the Middle East, in Syria, any place that there's a conflict, you can be sure that there's going to be these multi-drug resistant polymicrobial infections. And that's what we want to, that's what we want to stop. And we think that this is the greatest place that we can have to demonstrate that this is an appropriate solution to this terrible problem. Thank you very much.
Шановне товариство,
Dear colleagues, just a second. Any questions?
Є?
Questions, please?
Так, прошу, є в нас питання.
Yes, we have a question. Could you please have a microphone?
Маємо одне
So we have one question.
Дякую, я гадаю, що це швидко.
Thank you. I think it will be quick and we will be able to move on. Please.
Так, вімкніть нам мікрофон.
Yes, please switch on your microphone.
Фото просила.
Try again, please.
О, бачите, ви що? Будь ласка.
So now we can hear you.
First of all, I wanted to thank you about this beautiful about this opportunity for young doctors and rest of us today to learn about infection, especially in this cruel situation we currently all adjourned. My question is very simple. I want to know if you have some tips for some brave doctors on the front line that will help us avoid cross-contamination and bone infection for example, from bone infection before before casualty.
Я знаю, я знаю.
Yes, yeah. Before the patient arrived in
Так,
some clinic or
yeah,
all else.
я знаю. So the question is, what do you do at the front line to decrease the risk of infection? Okay. What is the number one thing, action, step that you can take to prevent an infection in a combat wounded individual? One thing only, makes the biggest difference in whether that patient will develop an infection. Ideas? Answer? Vidpovich? It's good surgery. It's good surgery, all right? You have to have good surgery, all right? And so these are devastating injuries, and these are not, in the United States right now, we have no experience dealing with the injuries that Ukraine is dealing with. We did up until a few years ago, but our involvement in Iraq and Afghanistan really was a low intensity, okay? We had maybe 3,000, over the period of time, we were 3,000 combat deaths after the surge. So it was a counterinsurgency conflict. And so the experience was very limited to a number of people who were there. Most of our surgeons in the United States have no idea how to deal with this, all right? And there isn't anybody to teach them except old guys like me, okay? So you have to be very aggressive, and this is part of the teaching that we have. You have to be very aggressive with your debridement surgery. And as I teach, if you have a hole this big in somebody's thigh, you have to make that incision this long, okay? Because it's the impact of that bullet, that fragment, or whatever it is, has a huge impact on all that tissue around you. And you can, and foreign material can get blasted into, so you have to open it up very widely. And you have to be very thorough. You can't be afraid of resecting muscle, taking muscle out. Muscle and fascia are not your friends, okay? You have to protect the bone, you have to protect the neurovascular structures, and that's why anatomy is key. Every surgeon is an applied anatomist. You have to know your anatomy. Anatomy is king. That's what governs all of our surgery. But it's adequate debridement and adequate irrigation. In our doctrine, a large wound requires 9 to 12 liters of fluid to wash it out. All right? That's a lot. All right? And then open wounds you leave open, closed wounds you leave closed. Okay? And then it's the proper use of antibiotics. So Haley is a clinical pharmacist, and she's the leader of this team. In my work as an orthopedic surgeon, I have relied heavily on my clinical pharmacists to give me the best advice. I can't remember all the drugs or all of the uses or contraindications or conflictions with this. So you need a great team. And that's what I think that she has put together with myself, Colonel Humanuk, Doug Davis, and others around some very, very smart people. I'm just a simple bone doctor. Okay.
Так, друзі, давайте подякуємо Hudson Berry, дякуємо за запитання.
Okay, dear friends, let's express our gratitude to Hudson Berry. Thank you for your answer. We will have some coffee breaks in our agenda. You've seen the agenda, so please feel free to approach our colleagues. And dear friend, are you satisfied with your answer? Amazing. Then we